Hey guys, myself Dr. Simran, and in this video we're gonna discuss about renal tumors. Renal tumors. Basically, in the previous videos, we have already discussed about nephrotic syndrome, nephritic syndrome, as well as the renal calculi. So these three topics have been discussed in details in my previous videos. So you can just tune into the you can just tune into my YouTube channel and subscribe it so that you can get notified whenever I upload a new video. So in this video we're gonna talk about renal tumors. Now let's talk about the renal cell carcinoma. Renal cell carcinoma presents with the flank pain, hematuria, which is the most common presenting symptom, palpable abdominal renal mass. What happens in renal cell carcinoma is that on chromosome number 3 there is a gene deletion. You have to remember that gene deletion is there on chromosome number 3. Now, important clinical correlation I'm going to tell you is that about the left-sided scrotal varicocele. Whenever a patient comes to you with left-sided scrotal varicocele that fails to empty when the patient is in recombinant position, then the first thing that should come in your mind is the renal cell carcinoma. Why? Because the tumor is obstructing the gonadal vein where it enters the renal vein. Now, whenever in the questions or whenever you come up with a question in a Q bank with the left-sided scrotal varicocele, that means that the renal vein invasion is there. Whenever you see a patient in the OPD, he or she is having left-sided scrotal varicocele, that means you should know that renal vein invasion has already happened. And let me tell you, whenever renal cell carcinoma is being diagnosed, it is in majority of the cases diagnosed at later stages, because in the early disease course the disease is basically asymptomatic. Now coming on to the paraneoplastic syndromes that the renal cell carcinoma presents with. The paraneoplastic syndromes are fever plus weight loss, which is common to most of the malignancies. These are called B symptoms. For all those who don't know the B symptoms, these are fever, weight loss, cachexia, etc., night sweats. Now the next is parathyroid hormone related peptide, which is the hypercalcemia, which will lead to hypercalcemia. It is not the true PTH, it is the parathyroid hormone related. So it will cause hypercalcemia. So the patient can also come with hypercalcemia. The patient would have cachexia. Cachexia is basically inability to maintain the lipid stores in the body or fat stores in the body. So the patient will be cachexic. Whenever there is a ectopic EPO, erythropoietin production in case of the renal cell carcinoma, so it would lead to polycythemia. Secondary polycythemia happens in case of renal cell carcinoma, although the most advanced tumors have polycythemia. Now, not just the renal cell carcinoma, but most advanced tumors are basically the secondary polycythemia. Now talking about the renin. Renin can be produced by the tumor, and thrombocytosis can also happen. That is, platelets will increase in number. Now originating from the PCT cells. Now you have to remember from where does the renal cell carcinoma originate. It originates from the PCT cells, that is the tubular epithelial cells. What is the shape of the renal cell carcinoma? You need to know that these are clear cells. They will look like this, polygonal clear cells with lot of carbohydrates and lipids. As there is a lot of lipids present, so the lipids would give the tumor the golden yellow color due to increased lipid content. Now, what are the risk factors that increase the probability of having renal cell carcinoma? It is smoking as well as obesity. Next, coming on to the important point. Now, when the renal cell carcinoma invades the renal vein, then for example there is a left-sided varicocele, it happens to affect the IVC. Then through the IVC it goes hematogenously, that is systemically, to the lung, to the bones. In the bones, the lytic metastasis would be there, lytic mets would be there. Majority of the cases the cause is sporadic. The small number of cases, you have to remember that in small number of cases it is inherited as VHL. VHL syndrome, you might have studied during your neurology, VHL basically is also a tumor suppressor gene, and renal cell carcinoma is the only abnormality associated with the deletion or mutation of this gene. This is important. Now jumping on to the next slide, basically the renal cell carcinoma originates in the renal cortex in the PCT. You have to remember this. There is a deletion of VHL gene, deletion on chromosome number 3. This leads to increased expression of IGF-1 and HIF transcription factor. Both of these, the expression of both of them are increased, which would consequently lead to increased PDGF, which is platelet derived growth factor, vascular endothelial growth factor. So once this is there, so more angiogenesis, more tumor angiogenesis there. Angiogenesis means formation of new blood vessels. So the tumor blood supply would increase. Tumor feeds on the new blood vessels. So this is how the angiogenesis is going to increase. Now what is the treatment? Either there is a surgical ablation for the localized disease, or you can also give the immunotherapy aldesleukin. Aldesleukin can be given, or targeted therapy for the advanced metastatic disease. Now you need to know that CT scan abdomen is the most sensitive and the specific test for renal cell carcinoma. Now coming on to the next tumor, you might be wondering that why I have mentioned neuroblastoma. I have mentioned neuroblastoma in this video because it is a very important differential diagnosis for Wilms tumor. Wilms tumor and neuroblastoma are the differential diagnosis. For what? For the abdominal masses in children. Now coming on to the neuroblastoma, it is the most common tumor of the adrenal medulla in children. You have to remember the age group. Less than 4 years of age children are affected. It originates from the neural crest cells. You need to know the origin. Neural crest cell, NCC, you can remember it like that. Neuroblastoma, neural crest cell. Now coming on to the next point, it is the third most common pediatric tumor. So what is the first most common? Brain tumor, then leukemia, then is the pediatric tumor, that is neuroblastoma. Now it can be anywhere along the sympathetic chain. Either it can be in the brain, either it can go in the abdomen. It can go anywhere in the sympathetic chain. Now what is the most common presentation? Most common presentation is the abdominal distension. The child would present with abdominal distension. Now the mass, how would the mass would be? The mass would be firm, irregular mass crossing the midline. Now crossing the midline is the main keyword, crossing the midline. Whenever you come across a question like this, crossing the midline, that means directly that it is neuroblastoma, because Wilms tumor does not cross the midline, and Wilms tumor is a smooth mass. It does not cross the midline. Now, Homer-right rosettes are seen in case of neuroblastoma, which are the circular groupings of the dark tumor cells surrounded by the pale neurofibrils. You have to know that what are Homer-right rosettes. Now coming on to the next point, HVA and vinyl mandelic acid, these are the catecholamines, these are the metabolites which are increased. Now next point is hypertension. Hypertension is less likely than pheochromocytoma. In pheochromocytoma, you guys might be knowing that there is episodic hypertension. But in case of neuroblastoma, the hypertension is less likely. Now coming on to the next point, the most common cancer in the first year of life. Most common cancer in the first year of life is neuroblastoma. The next point is paraneoplastic syndrome. Paraneoplastic syndrome, when we talk about it is opsoclonus myoclonus syndrome. It is really important because this is a peculiar thing that happens. The dancing of the eyes and dancing feet. That means there is a abnormal movement of the lower limb as well as the eyes. Homer-right rosettes I have already told you. And where are these found? These are found in neuroblastoma. They look like these, and medulloblastoma. Both of them have Homer-right rosettes. Now the markers for the neuroblastoma are bombacin and neuron-specific enolase, bombacin and NSE positive. There is overexpression of N-MYC on chromosome number 2. N for neuroblastoma, then N for neural crest origin, then N for N-MYC. So you have to remember the 3 N's of neuroblastoma, and you can draw it like this to remember it as Homer-right rosettes. This is how you should remember it, and you can draw 2 like this within the circle. Now it is a APUD tumor. APUD tumor, that is, it is amine precursor uptake decarboxylase tumor. Homer-right rosettes are the tumor cells around a neuropil. Versus, you need to know how do they differentiate from the pseudo-rosettes, which are the tumor cells around the blood vessels. Now, the Homer-right rosettes, let me write Homer-right rosettes. These are the tumor cells around the neuropil. You need to know what is in the center, neuropil. Whereas the pseudo-rosettes, what are pseudo-rosettes? Pseudo-rosettes are the tumor cells which are surrounded by the blood vessels. Blood vessels are surrounding the tumor cells. Now coming on to the next tumor, it is Wilms tumor. Wilms tumor is very, very common in children. Now it is the most common renal malignancy in childhood. It is the 4th most common childhood cancer. So I told you the top 3. First is leukemia, then is the brain tumor, then is the neuroblastoma, 4th one is the nephroblastoma, that is the Wilms tumor. You have to remember the sequence in which these appear. Now the age group of these is 2 to 5 years of age, whereas neuroblastoma was in less than 4 years. Now another important clinical correlation of Wilms tumor is that it happens, in various syndromes. There is a syndromic appearance. First is the Weger syndrome, then is the Danish-Drash syndrome, then is the Beckwith-Wiedemann syndrome. Weger syndrome can be guessed from its name itself. W stands for Wilms tumor, A stands for aniridia, that is the iris would be absent in a child. Then G is for genitourinary abnormalities, and R stands for mental retardation or intellectual disability. Now when we talk about the Danish-Drash syndrome, you need to remember like WEM. With WEM we stand for, W is for Wilms tumor, E is for early onset nephrotic syndrome. Nephrotic syndrome happens in case of Danish-Drash syndrome. The male pseudohermaphroditism, so WEM is like this, Weger, WEM. Now coming on to the Beckwith-Wiedemann syndrome, you have to remember a mnemonic W, M, O and H. W, M, O and H. Wilms tumor, macroglossia, the tongue would be enlarged. You have to remember, whenever you see a child with protruding enlarged tongue plus hemihypertrophy, hemihyperplasia, that means one side of the body. For example, this is the leg and this is the second leg. So one side of the body of a child would be enlarged as compared to the other. So this is hemihyperplasia, organomegaly like hepatosplenomegaly, etc. So these are the features. Now coming on to the genetic part, the Weger and the Danish-Drash syndrome, both are WT1 mutation. These are the loss of function. You need to know these words. These are really important. Loss of function mutations on chromosome number 11. Loss of function mutations on chromosome number 11. WT2 mutation is only one, which is Beckwith-Wiedemann. WT2 mutation is only one, which is Beckwith-Wiedemann. Now coming on to the clinical part. How does it present clinically? Basically, most of the Wilms tumor are asymptomatic. They are basically incidental, discovery by the caretaker, by the primary caretaker, like mother. So mother notices a abdominal protrusion or abdominal mass while bathing the child or taking care, or so she is the one reporting it. Asymptomatic child, firm, smooth abdominal mass which does not cross the midline. This is the main differential you need to know. versus neuroblastoma, which crosses the basically midline. Now, what is the treatment? Treatment is the tumor excision or nephrectomy plus chemotherapy plus minus radiation therapy. And what is the prognosis? The 5-year survival rate with the treatment is 90%. That means it has a really good prognosis. You have to remember, it's a good prognostic tumor. Now, Wilms tumor usually affects a single kidney, and less than 10% have bilateral renal involvement, stage 5 disease. Now, less than 10%, only less than 10% have bilateral kidney involvement. Although lungs are the most common site of metastatic spread, children rarely present with pulmonary symptoms. Lungs most common area of spread, but children rarely present with pulmonary symptoms. Now, abdominal ultrasonography should be the first step in imaging to differentiate Wilms tumor from other causes of the abdominal mass. So, for example, if a child presents with abdominal mass, the first step you need to do is you have to prescribe abdominal ultrasonography. That should be followed by CECT abdomen, contrast enhanced CT scan of the abdomen, to evaluate the nature and the extent of the mass, and of the chest to identify the pulmonary mets. So, CECT abdomen as well as chest, these should be done after the abdominal ultrasonography. Now, what is the treatment of Wilms tumor? Surgery plus chemotherapy with addition of the radiation therapy for high stage disease. Radiation therapy is added for high stage disease. Survival rates are excellent, especially if treated in the early stage. So, survival, as I already told you, that the disease has good prognosis, so survival rates are excellent. So this is all today for the today's lecture. I hope you like this video, and please motivate me, comment in the comment section just to let me know if you like these sessions, so that it would motivate me to produce more and more good content for you guys. Please like and subscribe my channel, and like my Facebook page as well as Instagram page named USMLE Star. Thank you.